Good morning and assalamu alaikum everyone. My name is Dr. Rida Mitha and I'm an intern at Khan University Hospital. I'll be presenting on frequency of postoperative posterior fossa syndrome in midline tumors at a tertiary care hospital. So pediatric brain tumors account for about 25% of all cancers, out of which 60% of these pediatric brain tumors occur in the posterior fossa. And the most debilitating complication after posterior fossa surgery is known to be the posterior fossa syndrome or the cerebellar mutism syndrome. It was first described in 1985 as a distinct neurosurgical complication following posterior fossa surgery of midline tumors. So it's a constellation of neurological symptoms after surgical resection of a posterior fossa tumor, and it's characterized by a reduction or an absence of speech, along with ataxia, emotional lability, hypotonia, and or urinary retention or incontinence. So most of the data so far is a representation of North America and European countries, and the incidence in prospective studies is shown to be about 11 to 29%. It's a well-known post-surgical complication. However, the pathophysiology is still not fully understood. Some of the characteristics of posterior fossa syndrome include mutism and reduced speech, ataxia, dysphagia, long tract signs, cranial neuropathies, cognitive and neurobehavioral abnormalities. It usually has a delayed onset of symptoms between 1 to 5 days post-surgery with an average of 1.7 days and a limited duration for about 1 day to 6 months. Most patients recover spontaneously, but the recovery is usually not complete. So the proposed pathophysiology of posterior fossa syndrome, there have been multiple theories about it. The most recognized one is an interruption of the dentate-thalamocortical pathway. So both the dentate nuclei are placed symmetrically in the parawermal area of the cerebellum in lobules 6 and 7. They receive their afferents from the cerebellar lateral ventricles and the primary and the supplementary motor area of the cerebrum through the pons. The efferents goes through the superior and middle peduncle and the upper part of the brainstem. They then go towards the contralateral ventrolateral nucleus of the thalamus and terminate in the primary cortex and the prefrontal cortex. So the theory goes that interruption anywhere along this pathway or bilaterally to the dentate nuclei can cause this posterior fossa syndrome. This particular pathway is responsible for cognitive functioning and the initiation of voluntary movements. Some of the other risk factors associated with it is involvement of the vermis or the brainstem, vasospasm, hydrocephalus, and others as well. So the rationale behind doing this particular research was that most of the published literature is from European countries and North America, and we wanted to see what the frequency of posterior fossa syndrome is in a resource-limited setting like ours, and if the risk factors varied from the current literature. Our primary objective was to determine the frequency and the risk factors associated with posterior fossa syndrome at a tertiary care hospital from a developing country. And we also secondarily assessed the recovery and quality of life of these patients. This was a retrospective cohort study conducted at the Khan University Hospital from January 2014 to June 2019. We reviewed patient charts for demographics, post-operative symptoms, imaging findings, histopathology, tumor characteristics, extent of resection, and the management of posterior fossa syndrome. Our inclusion criteria was all patients under 18 years of age with a primary diagnosis of posterior fossa tumor who had their primary tumor resection at Khan University Hospital. We excluded any child with prior neurosurgery or a tumor recurrence and or a syndromic or genetic condition affecting the brain. So we included 86 patients in this study during that time period. The posterior fossa syndrome frequency at our hospital was 54.6%. 47 of our patients developed PFS. The male to female ratio was 1.4:1 amongst those who developed PFS, and it was most commonly seen in patients 10 years or older with a frequency of 38%. Medulloblastoma was noted to be the most common type of tumor associated with PFS at a frequency of 42%, and it was closely followed by parasitic astrocytomas at 34% and ependymomas at 24%. And the most common tumor location was the fourth ventricle. In about 51% of our cases who developed PFS tumors were originating from the fourth ventricle. We assess patients based on gross total resection, subtotal, and biopsies. The most commonly done was gross total resection at a rate of 47%, with a subtotal resection at 38%, and 7 patients underwent a biopsy, which was at a rate of 15%. So PFS was correlated to the extent of resection, but it wasn't statistically significant. As in the literature, the surgical approach through Wormian splitting was most commonly associated with PFS. Postoperative symptoms. The most common postoperative symptoms seen was ataxia in 73% of our patients, followed by irritability at 68% and slurred speech at 57%. About 26.8% of our patients developed complete mutism postoperatively. Subjectively, most of our patients had partial recovery of speech and ataxia, but we noticed that patients who had deficits persisting for more than 6 months had these deficits to date with limited improvement. In terms of treatment, we gave them multiple treatments. Steroids was given to all patients pre and post-operatively. Physiotherapy and speech therapy was offered to all patients.
The last minute.
Yes. Physiotherapy and speech therapy was offered to all patients, and 68% of patients with PFS were helped with physiotherapy. Zolpidem was added to our treatment regimen post-2016, and we saw 32% of our patients who received Zolpidem had improvement of symptoms. So we did have limitations to this study. It was a retrospective study, and all data regarding surgical approach, tumor size was not always available. At our hospital, we get patients from different parts of the country. Most of these patients have been referred and have their reports and radiographic imaging done from outside hospitals and centers. So at the time of our review, we did not have all the data always present. So things like data of tumor volume could not be assessed, which could have shown an association with posterior fossa syndrome. Way forward, this was the first study to our knowledge on PFS from Pakistan. We do recommend prospective studies, and we hope to conduct more prospective studies at our own hospital with a larger sample size to find risk factors and predictors of PFS more accurately in our population. We would like to set up a national registry for PFS, and we recommend a multidisciplinary approach with regular meetings involving neurosurgeons, neuro-oncologists, radiation oncologists, and radiologists. Treatment plans should encourage use of high-dose steroids and aggressive physiotherapy in these patients. Zolpidem appears to be a safe drug for symptomatic improvement in these patients. We also recommend a telovelar surgical approach for posterior fossa tumor resection as opposed to the Wormian approach. And this would be it. Thank you so much.
Thank you so much, Dr. Rida. Do we have any questions? It's a nice topic to discuss, I guess, if you have any questions. Posterior fossa syndrome. I would like to ask a question from you.
Yes.
Did preoperative status of the patient had any impact on
Sorry,
this?
I didn't catch that. Can you please repeat?
Preoperative status of the patient had any impact on this posterior fossa syndrome or not?
Had any? I'm sorry, I didn't
Did the preoperative status of the patient had any impact on this posterior fossa syndrome or not?
Nothing that we could find as such.
Okay.
Okay.
Dr. Rida, these are only midline tumors or does that also include hemispheric tumors?
So in our study, we only included midline tumors because in our literature showed that mostly midline tumors reflected posterior fossa syndrome postoperatively. So that's what we focused on primarily.
Thank you, Dr. Rida.
Thank you so much.